James, are you having trouble? How you doing, James? James, are you having trouble? How you doing, James? Hello, James, are you there? James, are you having trouble? How you doing, James? Hello, James, are you there? Can you hear me, James? Hello, James, are you there? I don't see your audio on there, James. This says, looks like you're having a hard time getting in. Can't hear me yet. Hello? Can anybody hear me? Testing 1, 2. Testing 1, 2. According to my computer, I have it. Do you guys hear me okay? Can anybody hear me okay? Luckman or iPhone? Can anybody hear me? iPhone or Luckman, can you hear me, please? Let me know. Can you hear me? Can anybody hear me? Just text me and tell me. Oh, oh, that's another James. Okay. Hi, James. Can you hear me?
Yep, I can hear you.
Okay. Okay. How you been?
Good, good. How are you?
Good. Are you ready for the Mammoth Conference next week? Next weekend with Sammy.
Oh yeah, yeah. I think it's in a couple weeks, I think, right?
It's next weekend. Next weekend.
Oh, it is. Okay.
Yeah, it goes from 10 o'clock in the morning, Cairo.
Ah,
Uh,
hold on just one second. I'm getting a call.
yeah, go ahead. Go ahead. Well, that's probably for me. Could be for me. Oh, that's a China guy. Okay, I better get the link to him. Hello, Mohammed. Good day, Mohammed. Are you there, Mohammed? It looks like your audio's working. Hello, Square. Hi, Ibrahima. How
Hi,
you
hi,
doing?
hi, John. Hi, I'm good. How about you?
Good. How you
How's it
been?
going?
Good, good. How you
I'm
been?
doing good. Yeah, I'm also good. I'm doing well.
Nigeria,
going?
right? Nigeria, right?
No, Guinea.
I'm sorry.
I'm from Guinea
Kenny,
Conakry.
that's right. I'm sorry, I forgot. Yeah, you told me a couple of times, I think.
Yes. How are you? It's been a long time.
Very good, very good. Yeah, we have we have another webcast in a couple hours with Ike Cherry, and I don't know. I'll talk about it
Okay.
during the conference. And we have two
All
tomorrow.
right.
We have two tomorrow.
Tomorrow. Okay.
Yeah.
Okay. All right. So this
Okay,
one is about 8 o'clock from China, right?
Yeah, it's in 5 minutes, and it's from New Jersey. Actually, it's from the United States. James
Okay.
Leo.
All right.
James Leo.
Oh,
Cere-
all right.
yeah, please interact. Any questions? Okay.
All right. All right. I will.
Okay. Thank you.
Okay. Thank you. Good to see you. Good to talk to you. Thank you.
Hello, Mohammed Helmi. Are you there? And Harshad Parek. Are you there?
Yes, John, I'm there.
Good. I think Mohammed is going to host here. If he
Okay.
if he's there. Thank you for alerting me about the link.
Yes. I tried to register and I failed. So I
Yeah,
said, let me.
that was just there was a 1 minute phase where I changed the webcast, and you
Okay.
caught it. And once I
Correct.
fixed it. It was fine.
Right,
But-
right.
But I'm using a meeting
Okay.
rather than a webinar. There's a difference, and I need to get used to it because we have a
Yes.
huge conference next weekend, and I want to be
Okay.
able to use. It's called a breakout room. So
Okay.
stick around after the webcast. I'll show you.
Yes, yes. Certainly, certainly. Yeah.
Yeah. I'm gonna ask volunteers just to stick around so we can check it out, you know.
Yeah.
It'll give you a chance to, after the speaker speaks, to go into another room with
Yeah.
the speaker, because it's gonna be so busy, 100 speakers, you won't have time to ask questions.
Yeah.
So this will give you a chance to go in the room with the speaker
Yeah.
after he finishes. And then
Yes.
back onto the main Zoom after you're done.
Right. I think you did it earlier also. Same.
I think I tried it.
Yeah,
it.
you tried earlier. I know. I
Yeah,
remember
we
very
tried
well.
it. That was having a separate Zoom. Nargiza,
Yes, yes.
welcome.
Good morning, good evening, good afternoon.
Okay, you covered it.
Mm-hmm.
It looks like you're going hunting.
Yeah.
Yeah. Okay, I think Mohammed, are you there? You have to please check in because we need to get a host. If you don't have a good connection, I know I called you late there.
I will just
I-
try
I
to
do
join from
here.
laptop. 1 second.
Yeah, we'll have James, we'll have Harshad do it if okay, Harshad?
Yeah, John.
Yeah, I'm waiting for Muhammad, but he disappeared. So if he's not here, I'll ask you to host, okay? And
Yeah.
I'll ask you to introduce James,
Okay.
okay? Like you did so well, I think it was last week or the week before.
One second. John, I'll be back. I'll try to join from laptop.
Okay. Okay.
Yes, yes. Mhm.
James, we had our Muhammad Helmi here. He was going to introduce you, but he ducked out. So Harshad will introduce you if he doesn't
Okay.
pop back. Oh, he's back. He's back. Okay. Maybe it's a connection. We'll see. Okay, Muhammad, are you connected?
Yeah, can you hear me now?
Yes, I can hear you now.
Okay, great.
Can we see you now?
Okay.
Oh, there you go. There you go. Okay. Thank you for coming on short notice.
It's an honor.
And you know James, of course, right?
Of course. Who don't?
Good morning.
Yeah, good morning, Professor James.
One of your biggest fans, James.
You're in Egypt right now?
Actually, I'm originally from Egypt, but I'm doing my master degree in Khwashan Hospital under the supervision of Professor Shubin of Bypass.
Oh, okay, great.
Hopefully, one day I will come to your institute for a fellowship.
That'd be great.
Thank you.
Mohammed, where are you at now?
Khwashan Hospital, Shanghai.
In Shanghai.
Yes.
He's studying with Binzu.
Yes, he knows him well, right? You do a lot of interaction with Ben, right, Mohammed? Oh, I think it's a bandwidth thing. Mohammed, can you hear me okay? Well, we may have to go with Mohammed. Can you hear me? I
Um,
think Mohammed. I think we're gonna have to go with Harshad. Okay, Mohammed, I'm sorry about that, but it looks like you have some bandwidth issues. So, okay, you ready, James?
Yep.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning from Miami Beach. This is Dr. John Bennett of Neurosurgical TV. We have another in the series of the art of brain surgery. And we're going to have Harshad Parekh, a neurosurgeon from Mumbai, give James the proper neurosurgical introduction. Good day, Harshad.
Good afternoon, good evening, good morning, wherever you are in the world. It's my pleasure to introduce Professor James Liu, who is one of the most experienced microneurosurgery in skull base and vascular neurosurgery from US, and mostly his work is so enlightening to us, and we are here to listen to his master work again, and every 2 weeks we are listening to him. I was looking forward to see him in India when he was to come for a meningioma meeting, but I missed him. So James, I'm sure you will enlighten us this time again, and looking forward for your expert work. Thank you. Please go ahead and start.
Thank you, Harshad, for a very kind introduction. And thank you, John, for your technical organization here. Let me go ahead and share my screen. Okay, can you see this?
Yeah, perfect.
Okay, terrific. So I put this talk together and recently gave this at visiting professor grand rounds at Montefiore Einstein Medical Center and in my own institution. And the topic is largely derived from sort of why I decided to choose neurosurgery as a profession. And I was, as a young student, in deciding what field to go into, I was just fascinated by images of lesions in the center of the brain and questioned, how does one safely get to these things and treat patients that harbor, deep-seated lesions of the brain? And so I was fascinated by how you get there and also how you perform it and how do you do it without hurting the patient. So I titled my talk "The Roads Less Traveled," because I think when we talk about skull-based approaches, you go around the country, you go around the world, everyone has their top 2 or top 3 approaches, and oftentimes the other less traveled approaches tend to be overlooked, or some people even say they're not needed anymore. For example, when we talk about the skull base, I've heard many people say, well, all you need in your armamentarium is the pterional and retrosigmoid, and you can treat the vast majority of your skull-based lesions. And, I would argue that you should know all the different approaches in your armamentarium, and you can have significant advantages, especially getting to areas of the brainstem and the skull base. And same would be said about the endonasal approaches, and you could see that we can get to a lot of areas within the ventral skull base from the endonasal perspective, all the way from the frontal sinus down to the craniocervical junction. And so these are the approaches that we have in our armamentarium to the skull base. And we've talked about a lot of skull base approaches in this webinar series. But today I wanted to focus on a slightly different approach, and it's the approach to the deep areas of the brain, largely within the ventricular system, and then the pineal region, and also the tentorial incisura. And this is a fascinating area of the brain. It's a beautiful part of the brain, as you can see in this beautiful rodent dissection. The third ventricle is a deep area that's between a lot of important structures, namely the internal cerebral veins here, and also the medial posterior choroidal vessels. You also have the fornices, and these are critically important structures. If they're injured, you can have severe cognitive impairment and memory loss. And there are a lot of approaches to the ventricular system. These are the different approaches that you see in Roten's Atlas, and largely some of which are largely transcortical, meaning you transgress the brain to get to the ventricular system. But I've been fascinated by natural corridors. So, in skull-based surgery, we often use natural corridors, cisterns and crevasses. The endonasal is a natural corridor going through the nostrils without having to transgress any brain tissue. And today I wanted to focus on the different ways to maximize interhemispheric approaches to the deep areas of the brain. And the interhemispheric corridor is a natural corridor where you don't have to transgress any brain tissue other than the corpus callosum, but it really minimizes any perioperative seizure risk. And when you transgress these fissures, I think about how these mountaineers are traversing these crevasses and these glaciers to get to deep areas. And these crevasses are quite narrow. It's only a few millimeters, and you wonder how you can safely work in these corridors and treat very deep-seated lesions. So my talk today will be focused on this and how you maximize your working corridor, how you choose your corridor, and what are things to avoid so you don't get into any neurological complications. So let's take, for example, this large central neurocytoma. It's got classic features of heterogeneous enhancement. And here, this is probably one of the largest central neurocytomas I've treated. And you can see it really occupies both ventricular systems in the lateral ventricle. These tumors arise from the septum pellucidum, and it's causing severe obstructive hydrocephalus. And so if you think about the choice of approach, if you come at it through a transcortical approach, which is the more commonly traveled approach, you can see that you could get quite a large portion of the tumor. The approach is easy to do, a linear incision. You can make a small craniotomy and then get right into the tumor. The challenge is that you have a blind side on the contralateral side. It's hard to see cross-court underneath this area. And you can also have an ipsilateral blind side also as you're coming down this region in some cases. The alternative is to come in interhemispherically. And when you come in interhemispherically, the corridor may be tight, but there's a way to expand it, and you will be able to see both sides of the lesion, and you'll have equal access to both sides. And I've largely transitioned to doing all these interhemispheric approaches in the lateral position. There's a lot of advantages in doing these surgeries in the lateral position as opposed to the supine position. In the lateral position, you have gravity to assist the dependent lobe of the brain to fall away from the falx, and it helps create extra distance and increase your working corridor. The other thing is, as you're working, your eyes are parallel to the fissure. The fissure is parallel to the floor, it's parallel to your eyes, and it's also parallel to your hands. So it's a more ergonomically natural working ergonomics. So In this case, I'm doing a coronally oriented incision. The other thing to keep in mind is it's important to keep the head slightly flexed upwards so that the angle of the falx is going to come to a 20 to 30 degree angle from the horizontal of the floor. And this is important because this allows your eyes, as you're sitting, to have a natural line of sight down the deep target of this interhemispheric fissure. So with that in mind, the next decision is, well, which side do I put up? If I'm going to do a lateral position, do I put the left side up or the right side up? And my general rule is the lesion that is that goes more lateral to that side, which I believe was going to be the left side. This is the side that I choose to be on the top side when positioning, so that by gravity assistance, it's easier to see more lateral in a cross-cord-like fashion, and this portion will naturally fall down into the field. The other thing I do is an intraoperative ventricular drain. I put it after I open the dura in the same incision. That way you don't make a separate incision. And when you drain the CSF, it really opens up this corridor. You can get access into the fissure. You have to carefully open up all the arachnoid membranes widely, and you find the callosal marginal arteries. And then more deeper, you find the paired pericallosal arteries until you see the shiny white tissue of the corpus callosum. We can then safely make a callosotomy, roughly 2.5 to 3 centimeters, and then get right down on the tumor that you can see has a typical grayish appearance. These neurocytomas tend to be a bit vascular, but also a very soft tumor, very suckable. And here we're peeling the tumor away from the floor of the lateral ventricle and away from the fornix. You could see it's important to use very gentle tissue handling. I'm just using the bipolar to just gently sweep the tissue and the fornix off of the tumor and using a cottonoid patty to separate it. That's the last portion of the tumor. There's the choroid plexus. There's the foramen of Monro, where the choroid plexus enters. And then you could see here's the third ventricle. Here's the ependema of the third ventricle. And there's the other fornix going into, there's the third ventricle. And I'll almost always use a endoscope to take a look. You can see a spectacular view into the atrium posteriorly. And there's the head of the caudate where the tumor was adherent. You can see the adherence. This is where it's dissected away. So you can have a spectacular view. And all through this small fissure, you can get this tumor out entirely. He had existing hydrocephalus. He ended up having a shunt. But you can see this is the 2-year post-op scan, a complete removal, no deficits and no memory issues. He's returned back to work and he's maintained a normal life. You can see this is the size of the callosotomy that was performed. And he's done very well since then. So moving deeper into the third ventricle, these are the different approaches you can get to the third ventricle. It's a deeper area. Initially, though, you have to get into the lateral ventricle before you can get into the third. And there's many ways of doing it. There's the transforaminal route where you enter the lateral ventricle and then you can get the lesion out of the foramen of Monro. However, lots of times the foramen of Monro is a bit small and you can widen this corridor by using a transchoroidal route. And you just open up the tela choroidea, follow the choroidal fissure, and you can do this above or sometimes below the choroid plexus and open up this membrane, and it'll open up that transforaminal corridor to get out tumors in the third ventricle. My only criticism of this approach is that it doesn't give you a good, strict midline access. You can see cross court to the contralateral side a lot easier based on the angle. And oftentimes you're blinded on the ipsilateral side. And so to overcome that limitation, there's the interfornicale approach. And the interfornicale approach allows you to see equal access to both ventricles, and you have a more midline view. However, the challenge is you have to work between the two fornices. And this approach has largely been abandoned by most because of the risk of interfornicale injury, which can be very serious. It can cause severe cognitive impairment and memory loss. And so it's been largely avoided. This is one of those roads less traveled. And however, it's an approach that I do routinely in a lot of my cases. And I wanted to share with you some of the pearls on how you can do this successfully. And so how can we make this surgery safer, more effective? And should we even abandon this approach altogether? But I want to show you that it's still important to keep this in your armamentarium. This is a tumor a colloid cyst of the third ventricle that I treated in this young gentleman, and he had intact memory and was back to work, living a normal life. And the reason why I think interfornicale approaches are important is because these third ventricular tumors, and especially colloid cysts, can largely present into the roof of the third ventricle. The roof of the third ventricle, where these lesions arise, are within a potential space called the velum interpositum. The velum interpositum is where the internal cerebral veins situate, and it's bordered by a arachnoid membrane called the telochoroidea, which is above, and then a telochoroidea layer that's below. And these lesions are situated in between those two leaflets. So a lot of times, if you come in transcortical and you're staring into the foramen of Monro, what you'll see is sometimes these lesions do not present itself into the foramen. And what you'll see is a bulging septum pellucidum. And so in order to safely get this out, you sometimes have to transverse the septum pellucidum and to get these out. But if you come in through an interfornicale approach, you go between the two leaflets of the septum and you have beautiful access, and you can get these out and dissect the cyst wall off of the adhesions, which are often adherent to the internal cerebral veins and the choroid plexus. So here's an example, very large colloid cyst. She was shunted at another institution, and they did not feel comfortable removing it, so she was just shunted. But of course, that's not a definitive treatment. The colloid cysts continue to grow and become symptomatic. And you cannot do a transcortical approach here. The ventricular system is collapsed from the shunt. So we're going to do an interfornicale transcallosal approach. There's the corpus callosum. I've gone in between the leaflets of the septum. There is the ventricular catheter. You can see there's the septum that's bowed open. So now we're going to open up the leaflets. There's the cyst presenting to the foramen Monro. There's the two septum. I'm opening up the two leaflets of the septum pellucidum, and I land right on the colloid cyst. And it's important to maintain the turgor of the cyst. There's the internal cerebral veins posteriorly, but it's important to maintain the turgor of the cyst as you're dissecting it, because this is what gives you the countertraction to peel it from the critical structures. You want to be able to puncture the cyst and drain off a little bit, so it gives you a little decompression, but you want to maintain as much turgor as possible. And so now we've gotten control of the anterior portion of the cyst. And we're decompressing more of the cyst. There's the foramen of Monro visualized. I'm always visualizing the fornices. And there is the posterior choroidal vessel in the backside. And that's been coagulated and divided. And I know I've released all of the arachnoid adhesions from the veins, from the choroid plexus. And so now I can carefully deliver it. And there's the colloid cyst, nicely removed. You can see it's about 3 centimeters. And now I'm inspecting. There's the floor of the third ventricle. There's the basilar artery. You can see a beautiful view. There's the fornix. And there's the walls of the third ventricle. And there's the other fornix. There's the third ventriculostomy there at the bottom. So a beautiful view, complete removal, and it's a curative removal, because if you leave the cyst wall behind, you're going to have a recurrence. So her memory was intact. She's back to work, maintaining a normal life. So you can do this safely, interforniceel. The key is knowing the septum interseptal dissection and very gentle handling of the fornices. This is an example of 2 lesions. You can see there's a lateral ventricular lesion and a colloid cyst. Are these 2 separate lesions, or are these 1 lesion? Really hard for me to tell. My initial thought was maybe this was a colloid cyst that had ruptured and had a cystic component, but as you will see in this video, these were actually 2 distinct separate lesions. Very unusual case. But here we did a interhemispheric approach, and this, I believe, was left side down. And there's the tumor in the lateral ventricle. You can see it's largely avascular. And this turned out to be a subependymoma, which matches the imaging features. It does not enhance. And this tumor was adherent to the septum pellucidum and fornix. And you can see I'm using a scissors peeling technique where you keep the blades of the scissors very minimally open, and you can use it as a sweeping dissection tool. Very useful way of using the scissors. You're very gently, microscopically incising that arachnoid band, but then using the scissors to sweep and push away those adhesions off of the structures. And here, this is how we're able to dissect it off of the fornix. Look how the fornix is nicely preserved. It's basically untouched. If you use a blunt dissector, you will probably injure the fornix this way because it's blunt dissection. But this is a form of sharp dissection, which I think is very effective. Look how you can just carefully peel that off and completely remove this tumor. So that's the subependymoma. Now remember, there's a colloid cyst. Now look at the foramen of Monro. See how the foramen of Monro, there was no colloid cyst there. You don't even see it. The colloid cyst is all up in the roof of the third ventricle. So we're going to do an interseptal interforniceel dissection. There's the internal cerebral vein up here. There's the colloid cyst. We're dissecting it away from this internal cerebral vein. And we're now dissecting around it. You can see a portion of it is peeking out through the foramen of Monro here. So once we dissected the back part, we're going to come around the front part using the scissors technique. You can see it's quite adherent to the internal cerebral vein. And we're losing a little bit of the cyst turgor as it's drained largely. And I put a piece of gel foam in the interforniceel corridor to help push down the colloid cyst from the transforaminal corridor. So now I'm working in the transforaminal corridor, carefully dissecting around the cyst. There's the adhesion to one of the choroid vessels off the choroid plexus. And we'll carefully incise this. There's the last vessel here. You could coagulate it. And then cut that last vascular band. And there's the colloid cyst that's freed up. So this is now completely removed. So there's the two corridors. This is the transforaminal, and then this is the interforniceal working corridor. So this was done through two corridors, and this was a complete removal. Here's the post-op scan, and this patient was neurologically intact, no memory issues. We can apply these interhemispheric corridors as we think about brainstem cavernomas. This is a midbrain mesencephalic cavernoma in a patient who had repeated hemorrhages, had a left third nerve palsy, diplopia, and right-sided weakness. He had about 2 to 3 hemorrhages already and was essentially wheelchair bound. And when I showed this case to many colleagues around the country, the two approaches that were most discussed was a contralateral right orbitozygomatic approach, which comes through this angle, and you would have to make an incision in the front of the midbrain to get to the lesion. My only concern with this approach is that there's a lot of vascular perforators coming off of the top of the basilar artery. And I was worried about injuring some of those perforators. And the other approach that was discussed was a lateral supracerebellar infratentorial approach through one of the safe entry zones in here. And in this case, I felt that there was a good amount of distance of brain to transgress to get to this lesion. And I looked carefully to see where the lesion presented to. Was there a surface of the lesion that it presented to where I did not have to transgress any brain? And upon careful inspection, I could see that it presented itself to the wall of the third ventricle. So if I came in through a third ventricular approach, and if I came in cross-court from a contralateral approach, it would give me just the right angle to get to the entry point where I did not have to incise or remove any brain tissue to start removing this cavernoma. And so I chose a right contralateral transcallosal interforniceal approach. And it turned out to be a beautiful approach. It got me right to the lesion, and I was able to remove it within a matter of 10 minutes. And a complete removal. You could see the brain is largely untouched. And this is him 6 weeks post-op. Stable neurological exam, no incurring deficits. And his motor exam started to get better after we removed the cavernoma. So let's move and change a little bit directions. We were largely talking about interhemispheric to anterior third ventricular lesions. But what if you angle the microscope more posteriorly to get to posterior third ventricle and pineal regions? I think when we look at this pineal type of tumor, the most common approach that would be chosen or talked about in a group discussion would be a supracerebellar infratentorial. Classic approach to a pineal region, why not? But it comes with some risk of venous air embolism, particularly you do it in the sitting or semi-sitting positions. You can also come at it from an interhemispheric occipital transtentorial or even a posterior interhemispheric approach. However, of course, the internal cerebral veins could be in your way coming in this direction. But from my experience of doing anterior interhemispheric approaches, you can visualize that posterior third ventricle quite easily. And so if you think about it, if we go back to the Roten Atlas, we take a look at this beautiful view and we turn it on its side, doing it in the lateral position. This is the view that we're going to get. Once you go between the two leaflets of the septum pellucidum, remember that the fornices are more separated as you go from anterior to posterior. And then you have a beautiful view of the third ventricle, the cerebral aqueduct, posterior commissure, and there's the pineal gland. So this is the angle of attack to the third ventricle. Remember that you have to work between the paired internal cerebral veins and also the medial posterior choroidal vessels. So in this case, we're going to do a right side down approach for this tumor. And this is how the tumor is going to be viewed. So remember, I told you that these tumors are between two leaflets of telochoroidea. This is the superior layer to get into the third ventricle. There's the internal cerebral vein that's sitting in the velum interpositum. And then by the end of the resection, you can visualize this is the septum. This is the body of the fornix, which is at the base of the septum, and it's sitting right next to the choroid plexus. Same thing on the other side. This is the view that you want to see afterwards. So we published this particular case in Neurosurgical Focus video. This ended up to be a papillary tumor in the pineal region. It's a benign tumor. And if you remove it completely, it's curative. So there is the interhemispheric approach. Again, we're dissecting the interhemispheric fissure, much like opening up the sylvian fissure, spreading the arachnoid, finding the pericallosal arteries, and then you gently spread them so that you create a distance, a working distance in the corpus callosum. Using the stealth image guidance, we open up the corpus callosum to get into the lateral ventricle. And then once you're in the lateral ventricle, you have to get to the opposite lateral ventricle, which we do here. And now we're opening up the two leaflets of the septum pellucidum. And there's the telochoroidea. So what I use is, I use these bical sponges, and they look like gel foam, but it's not like gel foam because these don't stick. Gel foam will stick to the tissues after a long surgery, very difficult to remove. But we use these little spacers to hold the two septums apart. It's kind of like when you're changing a tire, a flat tire, you have a jack that jacks up this working distance. So we've opened up the telochoroidea. There's the tumor. We could start working on the tumor and start dissecting it from the walls of the third ventricle. And this tumor is very soft, very friable. And so we're able to remove this in a piecemeal-like fashion, carefully cauterize and devascularize the tumor. And this will be attached to the pineal gland posteriorly and also some of those posterior choroidal vessels. And there's the classic vessel on the backside that it's attached to. And we'll use an ultrasonic aspirator to help debulk some of this tumor. And this is all done retractorless. There's no need to retract the fornix because that can cause injury. So as you do this in a retractorless-like fashion using gravity assistance, gentle handling of the fornix, you can do this tumor resection very safely. And there's the final view. There's the third ventricle, choroid plexus, and body of the fornix. And there is the beautiful view of the cerebral aqueduct, posterior commissure, and pineal recess, just like I showed you in the Roten Atlas in the lateral position. And there's one choroid plexus and one fornix. There's the opposite fornix and choroid plexus. So everything is nicely intact. And we dry up the field, recharge the CSF with saline, And here we're putting in a ventricular drain. I no longer use ventricular drains. If I get good hemostasis, I prefer to leave no drains. It's just faster recovery and less time in the hospital. And here's the post-op scan, beautiful resection, complete resection, and normal neurological exam. We can use this approach for tumors in the tentorial incisura. And of course, this is a falco-tentorial meningioma. And a lot of ways to get at it that you see here. It's important to look at the position of the internal cerebral vein and the vein of Galen. This helps you determine, which approach. And in this case, the vein is on the bottom of the tumor. And so naturally coming from above through this interparietal precuneal trajectory gets you to the tumor. So you can see in this case, the tumor has grown in 3 years. You can see a significant growth of the tumor. The patient is more symptomatic. So we're going to remove the tumor and we're going to choose an interhemispheric approach. But there are several maneuvers we can do to get to the tumor. One is the transfalcine modification, where you open up the falx to get to the opposite side. So in this case, remember, like I said, I'm going to choose the larger tumor to be on the superior side in choosing a lateral position. So we're going to do right side up, left side down. So here's the picture, right side up, left side down, lateral position. And you'll see the tumor is very vascular, and it's right at the junction of the falx. This is a very classic view of these tumors, very hypervascular falx, right where the tumor is attached to along the falx. So we'll start with a little tumor debulking after we devascularize it. Then we can start to come around it extracapsularly. We can start to dissect it away from the ipsilateral parietal lobe with the use of gravity assistance. There's the corpus callosum anteriorly. And now we have control of the anterior pole of the tumor. And this is working in that retrocallosal corridor. Now we're going to incise the falx, and we're going to create this transfalcine corridor, which helps us get to the opposite side. And so we're going to open up this falx sharply. And then you can see there's the opposite side of the tumor. You can see the lobe of the tumor there. And now we're peeling the tumor from the corpus callosum. You can see the shiny white layer of the corpus callosum as we work from anterior to posterior, carefully removing these adhesions. Now, as you get along the backside of the tumor, this is where it gets potentially treacherous. You need to look for the vein of Galen. And you need to see where it enters into the falcotentorial junction. And if you're not aware of where this is, it's very easy to injure as you're coming around the backside of the tumor. And if you injure the vein of Galen, it's game over. It's not very forgiving. So you need to find where it is after some debulking of the tumor, because that's important on how you make the posterior cut along the falx. And I'll show you that in a minute. So now we're removing the tumor on the opposite side. We're using a suction sweeping technique to sweep the contralateral parietal lobe away from the surface of the tumor. And then as we come around in a clockwise fashion, we're going to get back towards the midline. And it's very important to continue to debulk because these tumors are large. And if you don't debulk it, it's the tumor blocks your vision, and by debulking it makes it more easier to manage. So it's easier to manage a smaller volume of the tumor. You don't want to be rolling a large tumor and not seeing a perforator on the backside being avulsed. And so now I'm trimming the tumor as close as I can to the falcotentorial junction. This is where the straight sinus meets the vein of Galen, and it's very important. You can see this in this Roten dissection. And you don't want to injure this junction, because if you occlude the venous flow, you can get some serious venous complications. So this is where I do what I call walking the line between radicality and functionality. I'm going to trim the tumor as close as possible, but leave the residual tumor that's invading the falcotentorial junction. So this is a beautiful view with the endoscope. There's a little bit of residual tumor that's invading into the falcotentorial junction. I'm going to leave microscopic residue here for radiosurgery. I don't want to injure the deep venous system at the cost of getting a gross total. So this is a radical near total removal. You could see here's the post-op scan. Here's the post-op scan, and at 3 months, I treated the residual here with radiosurgery. You can see no venous complications, complete recovery. So preserve those deep venous structures. Here's another example. This was a large falcotentorial meningioma, 64-year-old woman, lots of headaches. And again, it's important to study the venous anatomy. You want to know where that vein of Galen is, where the internal cerebral veins are. And in this case, I don't really see them. I don't see any vein here that's so obvious. Here's the internal cerebral vein, but then you lose the contrast flow, and then you see straight sinus. So I was confused by this. I had a feeling that the veins were on the bottom. So in that sense, I came from a precuneal approach. But was the vein occluded, and was there collateral flow? That's what I was not sure about. But in any event, you should always try to find these veins and preserve them. And I'll show you what we saw. This is a lateral position. I have since converted to a sagittally oriented incision. I just find that it's easier to open when you're doing a large tumor, and the wound heals very nicely. It's very anatomic. And so we put in a ventricular drain here. You can see the patient had hydrocephalus. And by draining the CSF, we can easily get into the interhemispheric fissure. There is the hypervascularity of the falx feeding the tumor. So we'll coagulate the vasculature and start devascularizing the tumor. You can see that in a lot of these cases, I'll use a retractor on the superior side just to lift the falx and retract the sinus a little bit. It really gives you an extra few millimeters of working distance, and it improves your light, your line of sight, illumination. And here what I'm doing is I'm using a Doppler to map out the inferior sagittal sinus and to map out a safe entry zone of the falx, so I can make that transfalcine cut and transtentorial cut without injuring the straight sinus. So the most important sinus here is this sinus right here. This is the straight sinus. If you're not careful and you injure the straight sinus, that's what's draining the vein of Galen. So you do not want to injure that. So now that I've found, and it's easy to get lost because the curve of the falx to the tentorium sometimes is very subtle. It's not so obvious in some cases. So using a Doppler to map out the venous system intraoperatively is very useful. So we've opened up the falx safely, and now I can deliver the tumor on the opposite side and bring it from the opposite side into my ipsilateral working field. And you can see the video is sped up here for time. We're debulking the tumor, very firm. And after some adequate debulking, what you'll see here is this is the backside of the tumor, the dangerous part. Remember the vein of Galen? Now there's a vein right here on the tumor capsule. It's very subtle, but it's very easy to miss. And it's very easy to start taking your bipolar and start coagulating the tumor capsule, right? That's what most people do in meningioma surgery. They start taking the bipolar and they go to town and they start burning the tumor capsule. And if you don't inspect the tumor capsule for any vessels, you're going to coagulate the internal cerebral vein that's going into the vein of Galen. So that would have been a disastrous maneuver. But look, I found that vein. I'm going to keep following it and following it and preserving it. And see these little droplets? These are tumor that I purposely trimmed off to leave a cuff of tumor on that internal, what I thought was the internal cerebral vein until proven otherwise. And so I'm lysing the arachnoid adhesions. And I want to preserve any vein that I see. So there's another attachment to the vein. This is the vein. This is a venous structure. There's tumor along the vein. I know this because I'm trimming it and I'm using very sharp dissection to trim this. Now look, here's the vein. This is the internal cerebral vein coming out of this is the splenium, the corpus callosum. This must be the internal cerebral vein, and you follow it, it goes up to the vein of Galen junction. You see that? And this is that straight sinus here. And this is a venous lake here. So this is a radical near total removal. Look how the brain is largely untouched, very relaxed at the end of surgery. And look at the postoperative CT venogram. This is very impressive. Remember how there was no visible internal cerebral vein preoperatively? You can now see the internal cerebral vein has reconstituted flow. So had I sacrificed this, I don't know how the patient would have done, but this patient did beautifully well. And it was all what I believe is from preservation of the deep venous structures. And here's the post-op MRI, post-op day 1. She went home on post-op day 3. And a great outcome. So we talked a lot about tumors. I just want to show you some vascular cases where the interhemispheric approach is used. I showed you the brainstem cavernoma, but we can do AVMs in this superior vermis as well. This is an AVM that ruptured. You can see the hemorrhage here in the superior vermis. It's a small AVM.
Was the interhemispheric parieto-occipital.
And here's the EVD. You see here, we put it right into the field, drain the CSF, and it really opens up this small working corridor. And you lyse the adhesions off of that tentorium. We cut the tentorium, a transtentorial approach to really get access to the vermis. And the beauty of doing AVM surgery early on when there's a hemorrhage is that the hemorrhage has already done majority of the work for you. It's already dissected 75% of the surfaces of the AVM. And so you don't have to do much work. You're just finding the vascular feeders along the non-hemorrhage sides. And look at the vein of Galen, spectacular view. Look how the brain is largely untouched. And then there's the post-op angiogram. She was neurologically intact. This is another AVM we did recently. This is a very large Vermian AVM. You can see a lot of vascular feeders. The size of this AVM was much bigger than the one that you saw previously. You can see it occupies a bit more of the vermis here. Tortuous draining vein into the Galen system. The other ominous feature is this. Look at this variceal venous aneurysm, large AVM, young patient, deep venous drainage. This has a lot of features that would increase her natural history risk of rupture, lifetime risk of rupture. You can certainly gamma knife this if you didn't feel it was resectable. But I believe this is a surgical lesion. This can be treated safely with surgery. My colleague did a great embolization, a staged embolization that we're feeding off of both distal SCA vessels, and it made the surgery a lot more manageable. So we did this interhemispheric EVD, drain the CSF, and we did this with the, I believe, the left side down, right side up. There's the falx. There's the vein of Galen, the splenium of the corpus callosum. So we're going to cut the tentorium. You can see it's the falcotentorial junction is not so obvious here. We're going to cut the tentorium to widen our corridor so we can see the top of the vermis. And what was interesting here was that the patient actually did not have a straight sinus. So if you studied the angiogram carefully, there was no straight sinus. So I was able to cut the falx, and I was able to, cut the straight sinus, and it really gave me a huge opening to the AVM. So here's the pre-resection ICG. I'm looking for the drainage of the venous flow. This is part of the draining vein here. And so here's the AVM. I can start to make a corticectomy and start taking these distal SCA feeders going into the AVM. You can see there's some onyx material that's outlining these vascular feeders from the embolization. This is somewhat helpful as a roadmap. And the rest of it is like just taking out a tumor. It's taking out a tumor by carefully coming around the tumor circumferentially. And then taking these vascular feeders step by step. So now that we've gotten more of the AVM dissected out, we're working anterior to posterior, working on the contralateral side. The most challenging part of these approaches is being able to see the opposite side. So here, using the retractor on the opposite side is very helpful. I can hold the contralateral cerebellum out of the way, and it's not using any excessive retractive forces. A lot of people criticize retractors, but if you use them properly and if you use it correctly, it's having another assistant, displace tissue away so you can be hands-free. You want to be able to be hands-free when you're doing delicate microsurgery. Okay, there are times of using the shaft of your instrument to retract, but sometimes you need to be completely hands-free to deal with important perforators and so forth. So we'll continue to work around the AVM. Now we've gotten the backside controlled. Now we're getting into the nice, shiny white matter around the AVM. Coming around the lateral, contralateral surface, and then connecting it with the inferior surface, rolling it towards the anterior part. And we're getting very close now to where that draining vein is. The draining vein that you see here, look on this diagram. See how the draining veins on the anterior portion of the AVM. So we're getting very close. Here's some onyx-filled feeders from the embolization. I believe this is going to be the draining vein here. There's the draining vein coming out of the AVM. We're going to carefully skeletonize it. And now we're going to coagulate the draining vein. I must say the embolization was very useful here. It really was no bleeding from the AVM, and the resection went very smoothly. it was just the right approach, in my opinion, doing it in this fashion, as opposed to doing it supracerebellar infratentorial. So this is the last portion of it, dissecting the last vascular feeder. And then you can see there's the opening into the fourth ventricle. There's an opening into the fourth ventricle. This was right at the bottom of the tumor. And there's the AVM removed. There's the resection cavity. And we do a post-op ICG and also a fluorescein angiography. I like to use this to complement my ICG. And then there's the final view. Again, the brain untouched. Here's the post-operative angiogram, complete removal. The only thing she had post-operatively was right-sided limb ataxia, which largely improved after rehabilitation. And then lastly, I want to show you this large AVM that was arising from the falx. This is a falcine pericallosal AVM. This is the angiogram. You could see that it was feeding from the left ICA injection, pericallosal artery feeders, huge draining varix. And look how it's fed from the external feeders. This is the ECA injection, and it's going all into the falx. You can see it's going all into the falx, into this big draining varix. Now, this case was shown across the country to a lot of prominent vascular and endovascular neurosurgeons, and vast majority of neurosurgeons said this was a dural AV fistula. Now, this is where it becomes critically important. This is where diagnosis is critically important. If you were to say this is a dural AV fistula, the treatment is largely treating it by removing the venous outflow. And that can be done either endovascularly or microsurgically. And I can tell you, if you eliminate the venous outflow, this AVM, if it was misdiagnosed, would have ruptured and it would have been a fatality. And the reason I know this is because I saw it at surgery, and I'll show you. This is the feeding from the contralateral side, right ICA injection, right ECA injection, again, very prominent vascular feeders, and also fed from the vertebral injection. So this was being fed by everything. And you can see very treacherous looking AVM, huge venous varix coming out of the falx, prominent scalp vessels, very ugly looking. And so I felt she had a huge lifetime risk of rupture. You can offer radiosurgery, but I felt that definitive treatment here was needed early on. So the diagnosis is important. Is this an AVM or is this a dural AV fistula? I wasn't quite sure, to be quite honest, but I went in there surgically to be prepared for both. I was leaning towards this was an AVM. So we did this in an interhemispheric dissection. The patient had several rounds of embolization before coming to surgery. And so here we are opening the interhemispheric fissure. And you can see typical dense arachnoid adhesions. And there is the vascular lesion here. This is the AVM. It's coming right out of the falx. What's interesting is that this AVM was entirely in the subarachnoid space. It was not a parenchymal cerebral AVM. You could see taking out all of these little feeders. It's like diffusing a bomb. Finding each one and then carefully eliminating one vascular feeder, one after another. And then carefully coagulating the AVM, taking our time. These AVMs can be treacherous, especially if you have an intraoperative rupture. So don't rush, take your time. There's the draining vein coming out of the back going into the vein of Galen. We're confirming it. Look at that early draining vein. Now, at this time, I was still interested whether or not this was a dural fistula. And when I put the clip on the dural fistula, the brain swelled immediately, and I took the clip off. And then over 30 minutes, the brain swelling came back down. And that's when I realized this was an AVM, not a dural fistula. So my strategy now is to cut the falx, which is the blood supply of this AVM. But you could see that as I'm cutting the falx, I get into these very torrential vascular feeders that you saw on this MRI scan. Look at this MRI. This is all vascular feeders. And the problem now is that the rate of the flow is overwhelming the ability of the bipolar to work. And also the bipolar is not the right angle to coagulate a falx. So I try to minimize the bleeding with a little gel foam packing. And at this point, I asked for some adenosine to give me an adenosine cardiac pause. And I'm also asking for angled bipolars from the nurse. And so I can induce a few of these adenosine pauses to try to slow down the bleeding. Finally, the angled bipolars come, and then I do another adenosine pause just to give me enough time to get that bleeding under control. Luckily, I was able to get the bleeding under control and then proceed with the resection. So the adenosine pause is a useful technique to do these high flow vascular lesions if you get into intraop rupture. So now that I've cut the falx, I can get control of the opposite side of the AVM. And here I am coagulating the opposite side of the AVM. There's the corpus callosum. And we'll continue to extend the incision of the falx more posteriorly. And rolling the AVM away from the corpus callosum. So this is the corpus callosum. You have a beautiful midline access, preserving these venous structures. And now we're going to get to the backside of the lesion here again. There's that draining vein. We're isolating the draining vein. We know this draining vein is going into the vein of Galen. So now we're going to do a pinch test. Look how the AVM swells every time I pinch it. So when you see that, it means that the draining vein is not ready to be ligated. There's more vascular feeders. Again, we get into more vascular feeders. This was a big feeder coming on the backside of that falx. And once we take care of that, we're going to repeat the pinch test in a moment. So the repeat pinch test, no further swelling of the AVM. So now we know that it's safe. I'm going to put a clip across this draining vein. And then after cauterizing the vein, we'll slowly incise it. There's the draining vein. And we'll continue to disconnect the AVM. And there's the final removal. This parafalcine pericallosal AVM with use of adenosine arrest, lateral position. And there's the final view. You can see the brain looks nice and relaxed. No contusions. Here's the post-op angiogram. No AVM. She's neurologically intact, with the exception, she did have a complication from the first embolization. She had a mild stroke after the first embolization, but no strokes after the microsurgery. So in conclusion, the interhemispheric approaches can be safely navigated to reach these deep targets in the brain. These natural corridors can be expanded by incising the falx and the tentorium to open up the corridors. Lateral position, I think, is very useful for gravity assistance, and also intraoperative CSF drainage allows you to use a retractorless technique. I like using the endoscope. It's helpful to look around corners, and it's most critical to preserve the deep veins and to perform gentle handling of the tissues, especially the fornix, for successful outcomes. So with that, thank you very much. Thank you for watching this series on the art of brain surgery, and thank you for your attention. I'll be happy to take any questions.
Yeah, thank you, Jane. Harshad, are you there?
Hi, John. Hi, James. Wonderful, wonderful. Excellent talk. Excellent presentation. All the corridors are superb. And technically, you were very, very sound. There's no question about it. And there is a lot to learn in that. And I agree with you about the various approaches you have described. And in a lateral ventricular tumor, if tumor is bilateral, yes, best to go from midline rather than going from a one ventricle. And you can be in trouble, otherwise you can't see the other ventricle. And neurocytoma, yes, gives a wonderful result and superb demonstration. One question I would like to ask you in posterior third ventricular tumor, your decision whether to go interhemispheric or whether to go suboccipital supracerebellar is decided by veins or but by the location of the tumors.
Yeah, I think for me, it's largely decided by the veins. So if the tumor is on the superior side of the vein, superior cerebellar is not a great approach, because in the sitting position or semi-sitting, you're staring at the veins before you can get to the tumor, and those veins are in your way. And in the sitting position, a venous bleeding is unforgiving. It will suck air and give you air embolism. So you should come from the top side, and you can either use an occipital transtentorial approach, or even better, the precuneal interparietal approach. I think gives you a better angle, and it avoids any visual cortex manipulation that can give you a hemifield defect. So precuneal is actually a more natural way of getting there. I rarely use supracerebellar approach anymore. I think a lot of them can be done in the lateral position that I showed you. But there are still instances where I think semi-sitting supracerebellar is useful. But it's nice to have all of these weapons, so to speak, in your armamentarium. So you can think about these problems with different options and figure out which one might have more advantage than the other.
If you see on MRI, the vein is being pushed up, then do you prefer to go from the supracerebellar or from the top?
Yeah, I think if it's like a classic pineal region tumor, I think supracerebellar is very, very helpful, especially if it presents itself more posterior. But certainly you can do this. You can do this easily now from above by cutting the tentorium. You have a beautiful view of the tumor. I don't like venous air embolism. It's a terrible complication. I've had one myself, and so maybe that's why I've favor this interhemispheric approach from above. But yeah, I mean, if it's a falcotentorial meningioma, I would not ever do it supracerebellar, because falcotentorial meningiomas are a different animal than a straight pineal mixed germinoma type tumor. It's very different.
You showed one case of AV fistula which turned out to be AVM and started bleeding. And you wonderfully managed by giving adenosine. And do you always keep adenosine ready in cases of like AVMs or any other surgeries in this area?
Yeah,
Or-
I think that's very important to think about and consider. So yes, I was prepared for adenosine for this case. I knew that if there was torrential, treacherous bleeding, I needed some mechanism to get vascular control. This is not a case where you can put a temporary clip and get vascular control. So it's important to think about these issues ahead of time and prepare your anesthesia team to have adenosine ready to go. Because the last thing you want is a disastrous situation and your team is panicking and trying to figure out where the vials of adenosine are. Meanwhile, you're bleeding and losing blood pressure. So it's always good to be prepared. I think any kind of vascular case, for an aneurysm case, you always have to think about, do I have enough proximal or distal control? And if I don't have enough proximal control, then you have to have adenosine ready. So I think having adenosine ready for any AVM surgery is very useful.
How many times you gave adenosine in this patient?
I think in this patient, I gave it 2 or 3 times.
You managed very well that bleeding. We could see the torrential bleeding coming, and the bipolar is hardly working.
Yeah, the bipolar was very futile. It was not the right angle, and there was too much volume and too much rate of bleeding that was overwhelming the system of the bipolar to work. So in order for the bipolar to work, it can't not be overwhelmed by the bleeding. So you have to slow it down either, by adenosine or something. And also having the right angle of the bipolar is very important.
Do you use navigation in all the patients or whenever there is a need?
Yeah, I use navigation in every case.
Very nice, very nice. Excellent presentation, James. As always, it is enlightening, lot to learn. One more question before I close. What do you say about the contralateral approach for either an AVM or a tumor when you go intrahemispheric?
Yeah, I think the contralateral approach is very useful. You have to look at the scan very carefully. Where I've seen some mistakes happen is I've seen colleagues use a contralateral approach for a very superficial lesion. So where the contralateral approach is useful is for a deep lesion, because the angle of your contralateral trajectory gets you a better view of the deeper target. Now, if the target is like a superficial parasagittal meningioma, the contralateral approach is not going to help you. In fact, you will miss visualizing the superficial part of the tumor because your angle is favoring a deeper target and you pass point whatever is more superficial. For those cases, just go ipsilateral. You don't need to do contralateral. So contralateral is for deeper targets, looking cross-court across the falx or something like that.
For a colloid cyst, do you prefer anytime transcortical approach, especially in the ventricles of the heart?
Can you repeat that question, Harshad?
For a colloid cyst, anterior third ventricular tumor, if there is hydrocephalus, do you prefer to go transcortical or midline approach?
Yeah, that's a great question. I still prefer to go interhemispheric. I think that's been my choice of approach. I think, of course, each case is different. You have to look at all the features. There are some cases I will do just transcortical, some intraventricular tumors that present itself right to the frontal horn. I'll sometimes I recently did a transcortical approach to a very large tumor because of the location. So I don't think I can answer it, in a general way. I think each case presents its own unique features, and I study the imaging carefully in each case to decide. So, in some cases, I think transcortical would be easier, more favorable. In some cases, interhemispheric fissure.
Right. Very nice. I use retractors in intrahemispheric approach, and I found retractors work very well. It doesn't retract too much of brain and doesn't cause any harm. And I agree with you, there is a definite help and your hands are free. So it is good to use retractors sometimes in that cases. It works very well.
Yeah.
Wonderful. Great talk. Great talk.
Okay,
Thank you.
Mohammed, do you have any comments? Can you
Yes,
speak?
sure. Yes, sure. First, thank you, Professor James Leo, for this wonderful presentation. As a young neurosurgeon, what I got from today's webinar is that a skull-based surgeon shall be technically patent, but I think most importantly, psychologically courageous. So may I know the position of the patient for the contralateral interhemispheric interferential approach for the midbrain lesion that you just showed us, and whether or not for such a tiny deep corridor, the self-retractor was used?
I think I used a retractor for the falx, like I showed you in the other cases. I usually use so I take the bone flap across the sagittal sinus, and when you open the dura, you can retract the sinus by a few millimeters. That increases your light and your illumination. And you could put a retractor on that top side to retract the falx upwards, to hold it up. It's basically a brain holder. You're holding, because by gravity in the lateral position, everything wants to fall down. You have to kind of hold things up by a few millimeters. It increases your light, it increases your working distance, and you're not going to injure the brain using the retractor. Let's remember, retractors don't kill people, people kill people. So if you use the retractors as brain holders, you use it safely, you use it properly. It's not a sin to use a retractor. Let's keep that in mind.
Okay, thank you.
Yeah, I'd like to recognize Ahmad Fawad Pirzad. He's the president of the Afghanistan Society of Neurosurgery. Ahmad, can you hear me okay?
Hello. Hello.
Welcome.
Hello. This is Dr. Pirzad from Afghanistan. Thank you. Thank you very much, Professor John, and the organizing committee. Thank you.
Thank you.
You're welcome. Thank you.
You're welcome.
Okay.
I do have one question.
Go ahead. Go ahead. Go ahead with a question.
John, yes, Professor, thank you very much for your nice presentation. I'm a young neurosurgeon from Uzbekistan. I have a question as a young neurosurgeon about managing obstructing hydrocephalus after surgery. So you mentioned about the patient with colloid cyst of third ventricle who came already with shunt. So after surgery, when you evaluate the patient, do you have in long terms the plans to remove VP shunt later on, or how to manage these patients? Thank you.
Yeah, that's a great question. Usually after I remove a tumor, I don't offer to remove the VP shunt later. I mean, unless the patient is very adamant about removing it. I always warn them that once you have a VP shunt, you may be dependent on the shunt. It's an extra surgery, and if it fails, then you got to put the shunt back in, and that's 2 surgeries, maybe even 3 if the shunt fails. So I tell them, if it's not broken, don't fix it. Let's not undergo any unnecessary surgery. And I've tried to wean some shunts before. I had several patients who, one was a recent case. She was a chordoma patient who had a VP shunt from another hospital, and she was having low drainage headaches. And so I tried to wean the shunt, but it was unsuccessful. So I ended up changing the valve instead. And there's a nice valve that I use made by Integra. It's called the Certus valve, and it has many settings. And at a setting of 8, it's they call it a virtual off. So it's almost like having an off setting on a shunt. So it's nice to have, but it turned out that the patient did not tolerate the off setting. So I'm glad I didn't remove the shunt. I only changed the valve, and I was able to titrate the setting to something that was more tolerable. So I think if patient already has an existing shunt, it's more than likely that their brain is starting to be dependent on it, and it'd be hard to remove.
Thank you. But if patient doesn't have a VP shunt, you will go for EVD or ETV, endoscopic triventriculostomy. So how?
Yeah, so if the patient has hydrocephalus and they come in, obtunded, of course you have to put an EVD in the emergency room or on admission and stabilize them. And then once you remove the tumor, you have a chance of not needing a shunt. So you could leave the EVD in afterwards and then wean it in the ICU. Now, if a patient has some hydrocephalus but is not terribly symptomatic, maybe just mild headaches, then I don't put in the EVD on admission. I'll put it in the operating room, like I showed you. I'll do the craniotomy, open the dura, and then I put in the EVD, and then I start draining CSF, and then it opens up the interhemispheric fissure. And then after I remove the tumor, after I inspect the cavity to make sure there's no blood in the ventricles, everything is clear, you have the option of leaving the EVD in post-op, or you can not leave an EVD. I used to leave an EVD routinely after every ventricular surgery, and the chance of needing the EVD was so low that after some time I transitioned to not leaving an EVD in post-op if the field was dry. And what I found was that it saved me a lot of time. Patients did not need long-term ICU stay, and the hospital stay was shorter. So that's something that I've changed over time.
Thank you very much.
Okay, keep an eye on Nargiza, James. She's a rising star in the Russian neurosurgery community, and she's put together a couple of webinars from Russia. So we look forward to them. Okay, any more parting questions, comments from anybody? Okay, very good, James. I'd like to thank you very much for the series and all you've done. And I'd like to tell everyone listening, we're experimenting with a meeting format with the Zoom. James is pushing the boundaries of neurosurgery. I'm trying to push the boundaries of Zoom. So anyways, next weekend's a big conference. James is going to speak there on the skull-based surgery with Samuel L. Morsi. And we're using the breakout rooms, which I want to experiment after we terminate this webinar in a minute. So stick around if you'd like to help us with this new platform. And James, thank you.
Thank you. Thank you, everyone.